Welcome to the AAN's Virtual Resident Education Lecture Series. Today, I am happy to announce Dr. Truong-Lee as our guest today. She is an assistant professor at the Department of Ophthalmology and the Department of Neurology at UT Southwestern Medical Center. She is a neuro-ophthalmologist that specializes in optic neuropathies, such as ischemic optic neuropathy, radiation-induced optic neuropathy, optic neuritis, neuromyelitis optica spectrum disorder, MOG-associated disease, Leber hereditary optic neuropathy, and idiopathic intracranial hypertension. Dr. Truong-Lee earned her medical degree at the Texas College of Osteopathic Medicine, as well as a doctoral degree in optometry at Pennsylvania College of Optometry. She has completed a neurology residency at UT Southwestern, during which served as one of the chief residents selected by her peers and faculty. She received further fellowship training through clinical neuro-ophthalmology fellowships at the University of Iowa Health Sciences School of Medicine and at the Massachusetts Eye and Ear Infirmary at Harvard Medical School. She joined UT Southwestern faculty in 2020. Dr. Truong-Lee's clinical and research interests also include neurologic conditions, such as ischemic optic neuropathy, radiation-induced optic neuropathy, multiple sclerosis, neuromyelitis optica spectrum disorder, myelin oligodendrocyte glycoprotein MOG-associated disease, diplopia, strokes, optical coherence topography, and visual field defects. She is a member of the Dallas Academy of Ophthalmology, the North American Neuro-Ophthalmology Society, and the American Academy of Neurology. Along here with us is, of course, Dr. Weber, who will be working on the Q&A. We'll be utilizing the Q&A feature, so please put all of your questions in the Q&A. There will be no questions taken, so please write them down, and Dr. Weber will ask them and answer them at the end of the lecture. Dr. Truong-Lee, we are so excited to have you here today. I will pass it over to you.
Thank you so much, Ben, and thank you for inviting me to give this talk to our trainees, which are the most valuable resources of our future. So I'm very excited because, as mentioned, I was previously an optometrist, and I was fully aware about how the eye works, and I was excited when I went to medical school later, thinking during my medical education, how soon I was going to be reinvigorated with the ophthalmology side of things in our classrooms. But that didn't happen. And I know it didn't happen to you either as trainees. So likely you don't know as much about the eye as you would like. And hopefully if you're attending and listening to this, that means you're looking forward to learning more and to applying this into your practice. Most of my lecture is going to be about how to identify and work on achieving what an optic nerve looks like, not to become an expert, but to be familiar, to be comfortable. Just like in neurology, the more you see, the more comfortable you become when you are seeing patients. So I hope I accomplished that today. I see a question in the chat. Do you want me to address that, or shall we wait?
No, I put that in chat to remind people to use the Q&A. You are free.
Thank you. Okay, so I have no disclosures, and today is the 23rd. I just want to orient myself. The outline of our talk, first, we're going to do a quick introduction into the visual pathway and the optic nerve, the fundus and the visual pathway connected to it. Just a very quick preliminary anatomy of a normal optic nerve, what you look for, the intraocular nerve appearance, and then the pathology of the optic nerve, what's wrong with the optic nerve that you're looking at, whether there's edema or no edema, and the causes of optic nerve disc edema, focusing on the history to make the diagnosis, and then the definition and typical causes of papilledema. This is the first time you hear me using the word papilledema, and I do that very conscientiously and on purpose. So masses, tumors, and IIH is the conditions we want to pay attention to. There are going to be 3 cases I'm going to talk about after we do this preliminary type of education to kind of get familiar, and I hope I keep you as engaged as possible. So let's start introducing you to the fundus. This is what, it isn't typical for you to take a direct ophthalmoscope and see all of this. This is a picture, it's an Opto's picture of the right and the left fundus, including the optic nerve, and you notice the coloration behind there. Most importantly, as a neurologist, what I want you to pay attention to are specific areas of the fundus. And that specific area is going to include the ganglion cell area. Ganglion cells are formed in the back of the eye in the retina and located in a very specific inner layer. It contains about 1 to 1.2 ganglion cells that are spread out and arranged in the fundus itself. And so, believe it or not, we have a total of 2 million cells, ganglion cells, which are nerve cells, inside inside the eye itself. That's quite a bit in the contour to the brain. I realize the brain is a lot bigger and we have billions of cells, but keep in mind that 30 to 50% of our brain subserves the function of vision. So that's a large part and large territory of our brain. And so examining the eyes is in part examining the brain. That's my opinion on that. So here is the visual pathway. This is a simplified version of what I want you to pay attention to. And starting at the light going in and hitting the retina, the first area I want you to pay attention to is that retinal ganglion cell. And it's the regular retinal ganglion cell then that sends the axons to join in to form the optic nerve. And from the optic nerve, which are actually collections of the axons of ganglion cells, it then travels back and joins together on either side from each eye to form the optic chiasm, as you may be familiar with. And from the optic chiasm, it proceeds towards the lateral geniculate, which then synapses onto another axon that travels to the visual cortex. So just keep that in mind as your structural layout and landscape for the visual pathway. The anatomy of the optic nerve is interesting. Keep in mind the area that we actually look inside the eye is as about 1 millimeter thick. And as you can see there, the picture of a dime, that's the amount that we're actually able to see when we examine the optic nerve itself. And surprisingly, as small as it is, it gives us so much in terms of information about what's going on in the brain. Overall, it's about 1.5 millimeter diameter, and behind the eye, it's about 3 millimeter because it contains the dural sheath. Here's a representation of from a schematic view of the eye itself from the outside, where you see the nerve and the blood supply. The blood supply to the optic nerve comes from the internal carotid artery, and the first branch of the internal carotid artery in the circle willis is the ophthalmic artery. I'm not going to test you on that. You really don't need to know that to discuss what we're going to discuss today, but just keep that in mind as familiar information for you. So let's focus on the intraocular optic nerve. That's the part that we actually examine the most. Again, that contains the axons of 1 to 1.2 million cells, the ganglion cells. And in the picture on A here, you can see that there are depictions of axons that are arranged in radial fashion that then travels in and goes towards the optic nerve. And so all those are coming from ganglion cells itself. And this is important because the arrangement of those nerve fiber layer then helps us to determine if there's vision loss and where in location it helps us to localize inside the eye, and as it organizes in the optic nerve, in the lateral geniculate, and further back in the cortex. So to understand what's abnormal, as you know, in the neurology exam, in the neural exam, as well as in the brain, first you need to know what's normal. And this is a picture of what a normal optic nerve looks like. And I want you to just kind of be familiar with it and look at it. And I'm not going to test you on small details or ask you to remember specific details about this, but there are certain features that's helpful to identify when you look at a nerve so that you know what's normal and what's not normal. In this normal optic nerve, the features are that it's round, and that's a typical shape of the optic nerve. It's flat. If it's elevated, there's concerns whether there's swelling or not. But being elevated doesn't indicate that it's swollen. It's just a position of the nerve itself. The margins are distinct. You can actually draw a circle around the nerve where the nerve ends and where the retina begins. The color is pink. We call it pink. It's the closest color we can identify, and it's been what we use in ophthalmology to describe the color of the optic nerve. The cup to disc is normal. There's a disc ratio inside where when the nerve goes in and turns 90 degrees, it causes a little shallow indentation that causes what we call a cup, and the disc is the entire nerve itself. The vasculature is normal. There's no attenuation, there's no sheathing, there's no color change, and you do not see hemorrhages. That is a normal optic nerve. So what's abnormal? There are variations to abnormal, but this is considered abnormal. You can see the picture of the normal on the right and then abnormal on the left. The color is different. The cup is different. And you may question, well, why is the color different? In this case, I want you to recall again that the optic nerve contains a bundle of axons from ganglion cell. You should have about 1 million of those axons. However, if you have some injury, if you have inflammation, or if you have something that will cause loss of nerves, then you lose those nerve fibers. And instead of having 1 million, perhaps the picture on the right there may have 100,000 left. And therefore, you're able to see the background of the nerve where the nerve goes through. And that background is sclera, which is white. And this is why you see a brighter color coming through compared to if you have denser amount of nerves. We describe that as pale in ophthalmology, and the more paler it is, the more likelihood of optic nerve injury and loss of axons in the nerve. And so the word pallor in evaluating the optic nerve is important to us. So that's important to keep in mind also. I showed you the arrangements of the nerve fiber layer where the ganglion cells are, and arrangements are important, just like in the brain and the territory and where locations are. It's the same with the optic nerve and the fundus. And as you can see in this picture, there's a defect that occurred in the nerve fiber layer in a certain specific area that I've circled. And that coincides to when we check their visual fields and vision, that area of the vision that corresponds to that area of the retina is affected as well, as I've circled. So that's how that becomes really important to identify where in the nerve it's affected. So what's wrong with the optic nerves when we see, and what are we looking for to determine what's wrong? There are different ways in which the nerve manifests when there's injury or infection or inflammation. You can see again the normal nerve. As you notice, I show the exact same picture every time because I want you to keep that in mind every time, the same picture, to look for nuances. And then you can see the next one showing swelling of the nerve. And keep in mind, I didn't say papilledema. We'll go into that in just in a little bit. But there's swelling of the optic nerve. And then proceeding further, after the swelling, if you injure enough nerves and the nerves die, you develop pallor, as we talked about before. So again, how do you determine what's wrong with the optic nerve? What features do you identify that shows that there's swelling or pathology of swelling? These are some examples of what a swollen nerve may look like. So we're going to talk about how to describe them. So if you were the one being called to the ER as a neuro resident, and someone has a headache and you think, well, I better look at the optic nerve because that's part of the neuro exam. How do you know if the nerve is swollen or not? Well, first look at the normal nerve and identify what the contour is, what the shape looks like, what the color looks like, and if there's any changes to the contours. So first off, what does an abnormal nerve look? What can it look like? First off, as you can see on the left there, I can't identify a cup such as the one I see on the right. There is congestion centrally. The color is certainly different. There's an elevation of the nerve. How do I know there's an elevation? If I follow the blood vessels from where it comes out and travel out peripherally, I can see that there's a little curvature that changes. And that's how I know there's a little elevation. Using our two-dimensional cues is helpful. There's obscuration of margins around the nerve, and there's obscurations of certain vessels. You can find a vessel that is centrally, but as you follow along, it becomes blurred by the fibers of the nerve that's being obscured and swollen. And then there are major vessels that might be obscured as well. So that's what you're looking for. If there are peripapillary wrinkles, It's because the nerve is swollen to the point where it pulls up the retina and it causes wrinkling of the retina around the optic nerve. The former name to that is called Patton's lines, but we're trying to avoid names and rather describing the finding itself, which is peripapillary wrinkles. You can also develop radial folds, and radial folds are folds that occur also because of the elevation and swelling of the nerve, which then causes these linear folds to occur from the nerve to the macula. So what are the causes that we can, what are the underlying causes that can cause these findings in optic nerves? Numerous. One, vascular and acute ischemic change to the nerve can cause swelling of the nerves, which cause all the findings that we talked about earlier, including hemorrhages on the nerve itself. One condition is known as anterior ischemic optic neuropathy with multiple causes. One can be arteritic versus non-arteritic. Optic neuritis, a central retinal vein occlusion can do this. Optic nerve tumors or orbital tumors. Leber's hereditary optic neuropathy in the acute phase can do this as well. Radiation-induced optic neuropathy. This is not an complete list, but a common list that we will see and investigate. So again, features of optic nerve swelling appear as all the features that we described prior. But then there's another condition known as papilledema. In papilledema, the optic nerve is also swollen. And what's papilledema then? I'm going to start to define it early on. So papilledema is a term that is defined specifically for a condition that results in increased intracranial pressure that then causes swelling of the optic nerve. So in order for you to actually call something an optic nerve due to papilledema, you should actually know if there's increased pressure inside the brain first. In this case, when you look at this nerve to the right compared to left, you certainly can tell that there is no cupping. There is central congestion. There's obscuration of margins. There are obscurations of vessels as well. I don't see peripapillary heme, so certainly they can be there. And I'm not certain that there's peripapillary wrinkles, but I do see all the elements of optic disc edema. And as I'm going to stress to you here, you can't tell the difference between papilledema and optic nerve edema caused by other causes. And that's important to notice. So what about these nerves here? We have what looks like an abnormal appearing nerve in both eyes, obscured margins, vessels are okay, some minor vessels are being obscured. I'd say both of those optic nerves, I hope you would agree with me, that they look swollen, or at least if you're uncertain, you can say that they're abnormal because you've already seen what a normal one looks like. So what's the difference again? The difference is in the pressure, whether there's pressure inside the brain causing swelling of the optic nerve or not. That's papilledema. Can you see pressure when you look inside the eyes? I hope you, if you do, you let me know how, because I have not been able to determine that myself. Now, there are some people who say, well, if you see what's called a spontaneous venous pulse, meaning that in 20% of people, when you look inside the optic nerve, you can see the vein at the optic nerve pulsating while blood is flowing through it. It is believed that perhaps then in case the pressure inside the eye is less compared to, or is greater or equal to the pressure behind the brain, and the pressure behind the brain is within 19 or 20 or low, and it's not high. That's the understanding. I found exceptions to that, so I do not follow that rule, and I don't consider that a true pearl. So depending on who you talk to, they may describe it that way. So really, you cannot see pressure inside the eye. In fact, like this patient here with this type of swelling, certainly you can see swelling all throughout with hemorrhages, very pronounced. And you might think, geez, that looks like pressure everywhere. Okay, wouldn't you say that that most likely is pressure behind the eye? What condition can cause that? Well, in this patient, there was pressure behind the eye, but this pressure is not increased intracranial pressure. This is a tumor, a glioma that occurred on the optic nerve, which compressed the optic nerve. Therefore, that pressure caused optic nerve edema. So we call this compressive optic neuropathy causing an optic nerve edema and not papilledema. Here's the pressure. This is optic nerve edema, not papilledema. Here's an example of another type of swelling that can occur. And the telltale sign of this is that if you've seen these before, the lower picture shows some curling of the blood vessels that's connecting between the vein and the artery. This is called cilioretinal shunt, or a retinal artery shunt that occurs between the vein and the artery. And this type of compression is a long process, is a chronic type of compression. And this type of edema, if you see on exam, is actually due to meningiomas. Again, you really can't tell the difference between papilledema and pressure behind the nerve due to meningioma. That's why truly there's more to papilledema than just looking at the eyes. Looking at the eyes is obviously important. How about this one? Does this look like papilledema to you? Well, when we have swelling in both eyes, it's more likely to be a central process compared to a peripheral process, because if you have something happening to the optic nerve, you can tend to localize it to one side. It typically doesn't occur on both sides, but there are always exceptions to the rule. I've seen this enough to know that. So I'm not going to commit that this is papilledema. And the reason why is because I don't know the history. I need to understand a little bit more about how they presented to determine if I believe that this might be papilledema or not. So I love this quote: "The mystery is in the history. The cause of optic nerve injury and pathologies often can be determined by reviewing the patient's history and how things came about. Is the vision loss associated with it, or is it not? How fast was it? The timing, how soon it reached the nadir? Any associated ocular systemic symptoms related to it? Any clues relating to the systemic changes or disease process? Medications is important, and any recent changes in medication, and any family history, social history, surgical history, and recent immunizations are important as well. So you really can't escape, even in ophthalmology, the history. And in neuro-ophthalmology, the history plays such a huge part of our exam. Just like in neurology, it accomplishes the diagnosis in 80% of the time. But certainly the exam is very remarkable. Just like an MRI and ancillary testing, the ophthalmic exam is very, very useful. So symptoms of increased intracranial pressure that you want to pay attention to, that will allow you to say, okay, what are the chances of swollen nerves to be papilledema? Headaches. Headaches that are worse lying flat. Headaches that are worse bending over, worse with cough or Valsalva, that wakes a patient up at night, worse with activity, worse in the mornings when they first wake up. Those are features of headaches with increased intracranial pressure. Transient visual obscurations. My residents tend to tell me, oh, this patient has transient visual obscurations, but I want them to tell me specific things that is described that correlates to a transient visual obscuration. And those specific changes include changes in vision when they're bending over, standing up, spots in their vision. They may have blackout that comes back, whiteout of their vision that comes back, changes in their distance focus and near focus ability. Because sometimes when swelling occurs, it changes the refractive error and in any tunneling vision that it can occur. Another very specific type of symptom that can occur with increased intracranial pressure is pulsation or tinnitus, pulse synchronous tinnitus, in fact. A whooshing sound, a humming sound, a machine sound that occurs on one side or the other, worse when they're laying down. That's a common one. Other associated symptoms include photophobia, nausea, vomiting, some confusion or mental instability. Those are rarer in occasions, but certainly it can happen in those patients with very high intracranial pressure. So once you determine that indeed these patients have these symptoms, or a likelihood where more of the positive answers are coming from these questions, then you may want to think about increased intracranial pressure, and perhaps you can correlate the swelling of the optic nerve to papilledema. So A refresher again, papilledema is optic nerve disc edema due to increased intracranial pressure. So again, if I ask you, looking at this, is this papilledema? Well, we'll need to know about the history. In fact, this patient actually has bilateral optic nerve edema due to ischemic optic neuropathy. This is a patient of mine. In other cases, if they have a history of diabetes and the A1C is out of control, you check their blood glucose and it correlates, perhaps that this patient may have diabetic papillopathy and not papilledema. Other scenarios may be that they're hypertensive and their blood pressure is 200 to 100, over 100. That might be an indication that they may have hypertensive optic neuropathy. And other features of the eye exam is helpful, such as this copper wiring, so exudates that occur, and these flame-shaped hemorrhages that can occur as well. In terms of ischemic optic neuropathy, there are features that I look for in the optic nerve that is quite helpful. If you've heard this description before, if the optic nerve is swollen but also pale at the same time, that is a very huge clue that there is active ischemia going on that is quite progressive and rapid. And that condition associates with arteritic ischemic optic neuropathy, as opposed to the non-arteritic ischemic optic neuropathy, where the swelling is obvious, but the coloration is not pale. Identifying that is really helpful because management is very different. And workup is going to be different as well, because you need to look at the inflammatory markers and obviously put them on steroids as soon as possible if you have any predilection or pre-test probability that this is arteritic ischemic optic neuropathy. But that's what the difference is in terms of the swelling of the optic nerve. In demyelinating and antibody-mediated types of optic neuropathy that causes swelling, there are various types of swelling that occur as well, and you really can't tell the difference between that and papilledema. And in some cases, you can have concomitant increased intracranial pressure and swelling of the optic nerve due to a demyelinating process. MOG or MOGAD is a very common one that associates with both that I often don't dismiss because I will find that they have increased intracranial pressure as well. Findings in optic neuritis, obviously a history of subacute loss of vision over 1 to 2 weeks, maybe spontaneous recovery in 1 month or so, painful eye movements. It's sensitive and specific in 90% of the cases. Decreased acuity of 20 to light perception. You'll find a relative afferent pupillary defect, so checking pupils is important, but we're going to focus on the nerve here. Visual field defects can be important. And you can also identify this Wolfrich's phenomenon or Olthoff phenomenon. Wolfrich's phenomenon is when a linear movement of an object does not appear linear to the patient, actually appears ellipsoid due to the difference between the vision between the two eyes. And Uthoff's phenomenon is when a stressor such as heat can cause delay in signal between the two eyes in one that has already been afflicted by optic neuritis. And then abnormal contrast sensitivity can occur too in the eye with optic neuritis. In terms of the longitudinal studies from optic neuritis treatment trial, we did determine that MRI images are quite helpful to prognosticate, but anymore it's not just to prognosticate, because we find that the optic neuritis swelling that can occur in patients with MOGAD and NMO are difficult to identify compared to those that are the typical optic neuritis. So most patients now, I would say 100% of my patients will get MRI imaging right away so that we can determine the pattern of enhancement to diagnose MOGAD, NMO, or typical optic neuritis. And the reason why is because treatment is differed accordingly. So in multiple sclerosis, you tend to have optic neuritis as a short segment of enhancement, and the recovery is pretty good, and they can have spontaneous recovery. However, in NMO and MOGAD, the pattern is different. NMO will have enhancement near the chiasm and a longitudinal segment of enhancement, and treatment needs to be instituted immediately because time is actually vision in these patients. And in MOGAD, the enhancement pattern continues on in the perineal tissue and around the orbit as well. And so if you can see that pattern of enhancement, treatment is very responsive to steroids. And these patients actually recover really well if they receive high dose steroids early on. And we do not stop steroids early as well. And that also changes management long-term if it's NMO versus MS versus MOGAD. So in terms of papilledema, I'm reiterating this again, because I'll share with you, this is my pet peeve sometimes with most of my trainees. I early on expressed to them that I would like for them to use the word papilledema correctly, and that is papilledema is reserved for optic nerve edema in relation to increased intracranial pressure. So what are the examples in which these things occur that can cause increased intracranial pressure? The most common things that people think about, not that this is the most common thing that happens, but in neurology, we think about idiopathic intracranial hypertension, and certainly we need to work this up. But there are many other secondary causes like hydrocephalus, a mass lesion like tumors and hemorrhages, and a large stroke can do this, abscesses, meningitis, encephalitis, a subarachnoid hemorrhage, trauma, AV malformations with high flow, intracranial or extracranial venous obstructions, and then again, pseudotumors rewrite like drugs related, tetracycline, minocycline, and so forth, systemic diseases, or eclampsia. So keeping that in mind, looking at this patient who's a 65-year-old man with headache and double vision, what's wrong with the optic nerve? Certainly doesn't look normal. Can you say that this patient has papilledema? Well, it turns out that this patient actually has a glioma. And in this case, the glioma was a space-occupying lesion, which indeed causes papilledema. And the papilledema, as you can see with the optic nerve swelling, you can't tell the difference between this and ischemia of the optic nerve. So to give this answer of whether that optic nerve is papilledema or not, the MRI was actually quite helpful. Do you need a lumbar puncture though? And because we don't know what the pressure is, could it indeed not have increased intracranial pressure? Could it be that the glioma involved the optic nerve itself? Certainly. And this is where evaluating, localizing the lesion and how it is causing mass effect to other structures of the nerve is helpful to determine whether there's increased intracranial pressure. I would say indeed, the space-occupying lesion did cause increased intracranial pressure, and therefore that was papilledema. But in the case that you cannot find a lesion itself and there is no tumors, what are some of the things that you can look for in MRI imaging and neuroimaging that can help to identify that there is increased intracranial pressure? And this is leading me to talk about conditions such as idiopathic intracranial hypertension. So some of the findings we look for in neuroimaging that can help us to identify increased intracranial pressure is the first one, showing flattening of the posterior globe. You can see that, in fact, there's a little bit of protrusion of the optic nerve in either side in MRI 1. In MRI 2, you can also, again, see flattening of the posterior globe due to pressure pushing forward. And then in MRI 3, let me move this. One of the areas on here is, there we go. It blocked my view. It probably didn't block your view, but it blocked my view. So again, more protruding of the optic nerve in MRI 3. Additionally, you should also see in the optic nerve sheath, there's white space around the optic nerve itself. That's the subarachnoid subarachnoid fluid that is filling up around the space, the meninges. And we can see more of that in this MRI. That indicates that there's so much fluid being pushed into the optic nerve due to increased intracranial pressure. MRI 4 shows kinking of the optic nerve that can occur due to the distension and pushing forward, and so is MRI 5. MRI 6 shows you that what we call empty sella, and that's due to the pressure, global pressure in the brain that causes this squishing of the pituitary gland, and so you see what we call an empty sella. Truly, the pituitary gland is still there, And in fact, it is a non-specific finding because we find that in patients as we age, we also have this flattening of the pituitary, and just finding an empty cella is not indication that there is increased intracranial pressure. But we get this consult a lot. Possible distension of the cerebellar tonsils. And in MRI-8, what it's pointing to is an area called Meckel's cave, where fluid can build up in there, and that's also a sign of increased intracranial pressure. Additionally, you can see venous stenosis or venous narrowing at the transverse sinus, especially at the junction of the sigmoid sinus. And in that area, due to the compression of pressure itself, this is my understanding of it, pressure from the brain that causes squishing of those veins because it's more malleable, and therefore you see narrowing of the venous areas and the flow as well. All right, so let me readjust some of these. Okay, so those signs there in a normal MRI indicates that likely this patient may have increased intracranial pressure due to a condition known as idiopathic intracranial hypertension. This diagnosis, though, is a diagnosis of exclusion. This is optic disc edema until you actually see elevated intracranial pressure. So certainly an MRI, an MRV to look at the venous drainage flow, as we saw earlier, and a lumbar puncture with pressure over 25 centimeters of water with normal CSF constituents. If you have inflammation, elevated proteins, increased cells, you need to determine if there's another cause for increased intracranial pressure. Risk factors include, and provocateurs include weight gain, obesity, and typically a sudden weight gain in a short amount of time is what I focus on, but certainly weight gain over time. Vitamin A derivative medications, Accutane, retinol, retin A, and ointments, and including minocycline, doxycycline, and tetracycline has been associated. Sleep apnea as well has been associated with this, and anemia. And patients who've been on steroids for long periods of time with a quick cessation, we find that this can be correlated with increased intracranial pressure also. All right. So I think that was a very fast and brief review of what causes a swelling of the optic nerve. I'm going to go through some cases. I hope this kind of puts things to use as you see patients. So case number 1 is this papilledema. This is a 72-year-old, I believe it was a man. I don't know why I didn't put the gender in there, with blurry vision in the right eye. 2 to 3 weeks prior, okay, it was a woman, she developed dirty glasses with shadows, but did not have any floaters and no headache or no eye pain. So that clue is very helpful. The history is quite helpful. Without headaches, without eye pain, it's not optic neuritis. It felt like dirty glasses. He didn't have complete loss of vision. No headaches indicate that this is not likely arteritic ischemic optic neuropathy. These are emergencies that you want to hop in right away. So she actually noticed it when she woke up and suddenly noticed this change in her vision. She didn't have scalp tenderness or jaw pain, and no weight loss or fever. Her vision was 2100 in the right and normal in the left. She did have a relative afferent pupillary defect on the right side. Her color vision was affected in the right eye. The left eye was okay. And you can see that the optic nerve shows, although her symptoms was in the right eye, she had optic nerve swelling in both eyes, and her visual field is correlated accordingly. There is some preservation of the central area in the temporal area in the right, on the left side, and temporal area in the right side as well. She had an MRI that was done and workup that included normal findings and everything except for an ANA that's 1 to 40, which is quite nonspecific and not indicative of inflammatory at this moment. And pre and post MRI was unremarkable. Nerves look good. Didn't really see flattening in the posterior globe, as you can see there. There was a little bit of narrowing in the left transverse sinus, but no thrombosis. And the flow to the rest of the venous system was normal. And so 10 days later, she returned again, and this is what she looked like. There's some resolution of the swelling, and indeed her visual field remained the same. In patients with arteritic ischemic optic neuropathy, the swelling would not have improved and the vision would have progressively lost quite quickly. So this patient actually has not papilledema, but bilateral, possibly simultaneous, non-arteritic ischemic optic neuropathy. She did undergo a temporal artery biopsy, and that was negative to confirm that she did not have arteritic ischemic optic neuropathy. And so patients that with this history, it's very common to have this condition. So in fact, when it occurs in both eyes, you definitely want to rule out temporal arteritis. But it's a typical story where patients will wake up and upon awakening will have this type of vision loss that can occur. It can be very similar to GSA in that they develop this transient change in vision that might come back, or it may stay permanent. There's blurry vision or decreased vision or loss of acuity. There's typically a relative afferent pupillary defect and some loss of color vision. And then this visual field defect that correlates to the area of swelling that can occur. And in the acute phase, there's swelling of the nerve that then resolves over a period of months, typically 3 months, and it can last as long as 6 months. And this is why we follow. In about 90, it occurs in about 90 to 95% of patients who have anterior ischemic optic neuropathy. And as I said, it's really in this awakened process from going to sleep, and most patients will wake up and realize they have this change in their vision. It's important to evaluate them because there's a risk of it affecting the other eye, and it's a higher risk. Depending on who you talk to, the risk is 14 to 25%. And the risk of it happening in the same eye is typically much lower, 1 to 5%. So is it papilledema in this case? I would say no, that was not papilledema. That was ischemic optic neuropathy. Case number 2 is a 27-year-old woman with a change in vision, no longer needing glasses, actually. She was wearing glasses before, and now she says, I don't need glasses anymore. That's weird. She has headaches every day. She has this pulse tinnitus that's worse when she's lying down. And when she went to have her eyes examined, this is what her optic nerves look like. And her visual field testing showed a mild enlarged blind spot. And that is due to that area of swelling that you see there due to the optic nerve causing the blind spot. So I'm hopeful that you can see the history now and realize if I see any indication of swelling to the optic nerve, I know what a normal nerve looks like, but her history really points towards increased intracranial pressure. And I would now agree with you that this does sound like papilledema. And in fact, the MRI findings on her did show flattening of the posterior globe, some distension of the the meninges around the optic nerve. They did do a lumbar puncture on this patient, and indeed the opening pressure is 34, which is higher than 35. And CSF studies with normal proteins, normal O-bands, and maybe a mild pleocytosis. So in this case, I would certainly say, indeed, this is papilledema. I hope that you will say the same thing. And so I'll ask you then, what is the diagnosis? And I will surprise you that this patient did not have idiopathic intracranial hypertension. In fact, when we do CSF studies, this is why it's important. We actually look for other secondary causes of increased intracranial pressure. That includes infection, inflammation. So we check for proteins and we check for infections as well. And recall, she had a little bit of pleocytosis, and her serology for syphilis came back positive. So this patient actually had syphilis, causing swelling of the optic nerve and causing increased intracranial pressure. Syphilis actually can attack the optic nerve itself and cause inflammation inside the eye, which is uveitis. So you can have inflammation of the optic nerve. In some cases, you'll get enhancement of the optic nerve. This patient did not have enhancement. And in this case, the neurosyphilis is what caused increased intracranial pressure, which then caused compression on the optic nerve, or rightfully called papilledema. So don't forget syphilis anywhere you practice. Case number 3, and last case. 28-year-old right-handed Black woman started noticing blurred vision in both eyes, along with a central floater in the left eye. This blurring is somewhat transient. It comes and goes, and it suddenly occurs when she stands up, when she shifts position, when she lays down. It comes into play. She has this pulsing sound in her ears that occurs 1 to 2 times a day. It's annoying. She has some symptoms of nausea. She's vomited a couple of times. She has a headache. She went to her primary care physician for this persistent blurring of vision. She had a pregnancy test that was positive. So they discontinued certain medications that were related, that she was taking for concern of fetal involvement. And so after that, she was referred to the optometrist for the visual symptoms to get it corrected. Her medical history has some depression, anxiety, OCD, headaches, and she has a BMI of 37.2. In terms of ocular history, really just refractive error, no trauma, and no other episodes prior. And she has some prenatal vitamins that she's taking, and she stopped those psych medications, as we mentioned earlier. Family history of cataracts. Otherwise, she doesn't smoke, doesn't drink, and doesn't use drugs. Her vision is actually 20/20 in both eyes, and she doesn't have a relative afferent pupillary defect. The rest of the exam is really normal, but the fundus exam showed what we call frisson grade 2 swelling of the nerve of the disc edema, and that's what it looked like. So frisson grade 2 indicates that there is circumferential blurring of the margins of the optic nerve itself. That's our grading scale for swelling of the optic nerve. Her visual field looks really good. She has this enlarged blind spot that was there. So right now, it sounds like she might have increased intracranial pressure, but vision-wise, she's doing really well. Here's her MRI. You do see flattening of the posterior globe. You see, otherwise, not really an empty cella, maybe a partial empty cella if you really look really closely, but otherwise unremarkable. And she does have a little bit of narrowing in her right transverse sinus, otherwise within normal flow throughout the venous, the MRV. She did undergo a lumbar puncture, and her opening pressure was 37.5, and her CSF constituents, including syphilis, was normal. After the lumbar puncture, her transient visual obscurations that she described earlier improved, and she no longer had those symptoms. So this is idiopathic intracranial hypertension. In idiopathic intracranial hypertension, again, we have to really rule out all the different causes, which means the workup should include MRI, MRV, and a lumbar puncture, and the studies of the CSF in the lumbar puncture. The Dandy criteria for idiopathic intracranial hypertension includes symptoms of increased intracranial pressure, absence of any localizing findings. One non-localizing finding that you may find is a 6 nerve palsy in some patients who have increased intracranial pressure that causes them to see double and causes the eye to turn in. Finding of any neurologic finding in an exam should be normal. Neurodiagnostic testing should be normal, and no other causes for increased intracranial pressure, as we said. Risk factors are patients who are female, but not excluding male patients, overweight, recent weight change, typically weight gain at childbearing age. Symptoms: daily headache, pulse synchronous tinnitus, TVOs, and truly papilledema. The papilledema is graded by Frisson scale. A grade of 1 is obscuring of the nerve in a C-shaped pattern with sparing of one sector. Typically, it's a temporal sector. And then grade 2 is complete obscuration of the margins. Grade 3 is complete obscuration of the margins and obscuration of a major vessel. And then grade 4 is more than one major vessel, and 5 and on is going to be all the major vessels. And sometimes you'll see hemorrhages and radial folds and peripapillary wrinkles. So we reviewed the workup for that. There are other technologies that we use in our neuro-ophthalmic exam that can help us to identify loss of nerves and axons. I don't want to focus on that too much today. That's more extensive in the neuro-ophthalmic process. I can certainly revisit on another lecture. And of course, there's so much more in neuro-ophthalmology to explore. So I'm so excited, and also thank you for allowing me to express my interest in showing you about the optic nerve and what optic nerve can help us to identify in patients. So hopefully I've achieved some of my objectives today, and that is to introduce you to the Fundays exam, being comfortable at looking at the optic nerve, meaning that just to see it itself and being familiar with it is really important, so that when you see it, you can look for features. We reviewed some of the optic nerve appearance in edema versus normal. We reviewed what it looks like in increased intracranial pressure. We've now identified and defined papilledema. I hope we use the word papilledema in the right context. And we've talked about workup of IIH and the importance of the lumbar puncture. Thank you so much. I look forward to any questions.
Thank you very much. Everyone, please put your questions in the Q&A section. I will try to get to them as they come across. Great talk. Thank you very much. I had some question. Have you ever seen a unilateral papilledema?
Yes.
And what would cause one eye to react to the increased intracranial pressure as to both?
Yeah, that's a great question. No other explanation other than variable anatomy. Why one nerve the fluid went to one nerve and not the other. We don't know. I mean, everybody's structure is different. But certainly this is why, as a neurologist, we focus on the history. And when we see one sign, don't be dismissive that this can't be increased intracranial pressure. There are always exceptions to everything. So that's why I say, don't make conclusions until you've done a thorough investigation.
I think I've seen a case report once of I can't remember what, some sort of tumor pressing on one optic nerve, causing pallor, a shrunken nerve head on that side, and then papilledema on the contralateral side.
Yeah, there's a name for that.
Yeah, there was. My neuro-ophthalmologist taught me, and I've forgotten.
Yeah, so that's called the Foster-Kennedy syndrome.
Yes.
Yeah, Dr.
That's specific to some nasal tumor, right?
Yes. So back before, when they actually were examining the eyes, they didn't, the way we examine the eyes now, he noticed, Dr. Foster, he noticed that when he saw pallor in one, swelling the other, there's a high chance that there was a tumor located above, before we had CTs and MRIs. And indeed, when they did the autopsy, they would find that tumor there. So that was the Foster-Kennedy sign.
Fancy. Are there any specific, like, what are your hot button scary findings that the resident calls you about overnight? What are the answers that make you think, yes, this is an ophthalmologic emergency, I need to do something right now?
So a young lady coming in with pain with eye movement, and or an older patient in their 50s and 60s coming in and loss of vision in both eyes, and look in there, and there's swelling with hemorrhages. That's probably my first indication. The second is what the visual acuity is. If the visual acuity is 2200 or more, that's when I say we need to do something immediately. And what I'm thinking about is conditions I can treat and reverse immediately. And those conditions include giant cell arteritis. So if you have swelling of the optic nerve with hemorrhages, loss of vision 2200 or beyond, and concomitant features like headache and eye pain, I would want to either image them immediately or give them steroids immediately. So those are the two scenarios.
Did you give them steroids while you rolled them to the imaging, just to cover all your bases?
Yeah, I mean, if it's not going to alter management, again, that history is so important. I mean, if you come in and you tell me, my granddad, who's 70 years old, he's been having this headache, he lost weight, and all of a sudden he can't see on one eye coming down. I look inside and the nerve is swollen and pale. I'm giving him steroids. And then I'm going to address the other things, just because I know that I can reverse that vision pretty quickly if this is giant cell arteritis. Hopefully.
Not to take you too far off topic, but what is your 30-second treatment paradigm for IAH patients?
Initially, I start off with acetazolamide. Rarely do I have contraindications to acetazolamide. And often if you educate your patients appropriately in terms of their side effects, they tend to stay on them. And what I mean by that is that everyone has tingling when they take this medication around the mouth, around the hands and feet. And I always tell my patients, oh, that means it's working. Because it is, you're getting it through your system. And secondly, over time, those symptoms actually get better. And we can help mitigate that with magnesium and potassium supplements, and making sure their electrolytes are okay. We find that improves over time. So that's my first. And after that, I will increase maximum dose I start at 500 twice a day. 250 is really not enough, truly. And 500 up to 2 grams twice a day. And if that is not achieving my goal, I will have, I may add topiramate on top of that. Very rarely, I may do 3 medications, and that's LASIK on top of the acetazolamide and topiramate. But most of my patients do respond pretty well on acetazolamide. I do have a handful on 2 grams twice a day, and they do great. If the patient has what we call fulminant IIH, and that description, and there's a great paper written, I think it was Dr. Burchard in Boston. In regards to a condition known as fulminant IIH, where the vision loss is quite rapid, within weeks, they progress quite quickly to lose visual field, color vision, and the optic nerve swelling is very significant, grade 4 or 5. Those patients may need to do procedural treatment, and that may mean optic nerve sheath fenestration, or VP shunt, or stenting, depending on where the pathology we might target. But it's pretty something that needs to be acted on quickly. In some cases, we actually admit the patient. My training in Boston, we actually had 2 patients we had to admit and put a lumbar drain to temper the pressure immediately, and that actually showed improvement within the next day or 2 with visual fields and swelling. And those patients actually ended up with a VP shunt when I was taking care of them. And the results of that was actually pretty good. The vision came back. One patient achieved 20/40 vision, and her visual field improved significantly. So those are, did that answer your question? You were asking 30
Yeah, I mean, it wasn't like that. It wasn't directly related to the topic, sort of tangential, but I always like to get other people's insight on sort of what you start with and when you would pull the trigger on doing something more invasive, like the VP drains, the VP shunts, and the fenestration. So yeah, that was great. I think that's about time for us. So I'll pass along things to Ben. Thank you again.
Wonderful. Thank you, Dr. Weber, for those questions. And of course, Dr. Truong-Lee, thank you so much for being here. That was incredible. And as a reminder to everybody else, this will be recorded and put onto YouTube. In the chat, I have posted where our YouTube channel lives, as well as where it lives on our website. Thank you again for everyone who participated, and we will see you next month in March. If you have any questions, feel free to contact us at the AAN, and we'd be happy to answer them. Thank you again, Dr. Truong-Lee.
Thank you.